Good evening. Welcome to the Hemophilia Federation of America's Blood Brotherhood Program webinar series. Thank you for joining us tonight. My name is Eric Bergeson, and I'm HFA's Media Specialist. Before we get started, I'd like to go over a few helpful webinar tips. Tonight's webinar will last approximately 1 hour. We certainly welcome your participation and questions during the webinar. However, your audio will be muted during the entirety of the webinar, as this helps limit background noise that may disrupt the presentation. If you have a question, we encourage you to type the question in the box located at the bottom of your control panel. I will then pass your questions along to our speaker. HFA would also like to thank Shire, CVS Specialty, as well as CDC collaborative partners for their support of HFA's Blood Brotherhood program. They help make these educational webinars possible. Tonight's presentation is Men's Sexual Health, an important overall health indicator. In this educational webinar, attendees will learn about the most common sexual health issues facing men today, why sexual health issues are an important overall health marker, and ways men can start improving their health and preventing other chronic health conditions. Tonight's presentation will be led by Dr. Kevin Billups. Dr. Billups is a urologist who has focused his practice and career on men's health and sexual medicine for the past 25 years. Dr. Billups received his medical degree from the Johns Hopkins University School of Medicine in Baltimore, Maryland, and his undergraduate education from Harvard University. Dr. Billups completed a residency in urology at the Johns Hopkins Hospital Brady Urologic Institute. He then went on to receive fellowship training in sexual medicine, male infertility, and vascular biology at the University of Virginia in Charlottesville, where he was honored as an American Foundation for Urologic Disease and Robert Woods Johnson Foundation Scholar. Dr. Billups has also authored numerous academic papers on topics concerning the link between men's health, cardiovascular disease, and sexual medicine. He has a special interest in clinical interventions using erectile dysfunction and testosterone deficiency as predictors and early warning signs of chronic medical conditions such as diabetes, heart disease, and hypertension. Dr. Billups is also actively involved in the National Medical Association, where he currently serves as the Urology Section immediate past chairman from July 2012 until June 2016. Dr. Billups served as the director of the Men's Health and Vitality Program at Johns Hopkins. In July 2016, Dr. Billups started his position as executive director of the Meharry Men's Health Program and professor of surgery and urology and medicine at Meharry. Sorry, Dr. Billups, I think I'm butchering that. Medical College School of Medicine in Nashville. Before we begin Dr. Billups' presentations, we do have a few questions we'd like to ask of the audience. The first question would be, which of the following represent the earliest symptom of erectile dysfunction? The options are inability to achieve a rigid erection, inability to keep or maintain a rigid erection, both the inability to get or keep a rigid erection, or a painful erection when rigid, or none of the above. So we'll give attendees just a few moments to reply and then move on to the next. And it looks like we have the results. Split decision so far, and I think we'll move on to the next question. Which of the following statements about testosterone is false? Choose one. Increased belly fat is an important cause of low T levels. Low T is often related to poorly controlled diabetes. T replacement therapy is known to cause prostate cancer. Low T might be a risk factor for heart attack or stroke. And finally, increased belly fat associated with higher estrogen in men with low testosterone. Looks like increased belly fat wins that one. So on to our last poll question before we start the presentation. Getting less than 6 hours of sleep does which of the following? Increases the risk of obesity by over 20%, increases the risk of stroke by over 20%, increases the risk of diabetes by over 20%, increases the risk of coronary artery disease by over 30%, or all of the above. looks like all of the above takes the day. We'll, hint, hint, we'll be circling around back to these questions at the end of the webinar. But for now, would like to hand over the presentation to Dr. Billups. Thank you for joining us this evening.
Okay, thank you, Eric. It's a pleasure to be here. Let me just get started here. These are my disclosures, really just on the Speaker Bureau for AbbVie, which will have really nothing to do with the presentation that I'm giving tonight. So let me start out by just going over some general facts for American men today. Just some general facts that 25% of men report they don't have any usual source of health care. Many of the deaths that we see in men are premature. About 50% of these deaths are premature, and we'll talk some about the steep social and economic costs for individuals and family. I often say when I give talks that as men, we take better care of our cars than we do of ourselves, which is probably a pretty poor commentary, but it's true. And the current focus today is on sickness and acute care rather than early detection and prevention. So these are just some general facts, and I'm going to go over these. As Eric said in the introduction, I'm a urologist, and most of my career, the past 25 years, and most of it has been focused on the whole idea of men's health. So that's what we're going to delve into today. But let's just take a second and look at why do we have this problem with men's health? Because men's health is a very common problem. I think this all goes back, if you look at the slide here, it goes back to, if you compare men versus women, if you look at the health trajectory for women start out with pediatrics. Many of them will play sports, but they get to the gynecologist early on in life. So they're at the gynecology office early, and the gynecologist either becomes the primary care physician or will pass them on to a family medicine doctor or an internist. So women get plugged into healthcare early. But let's look at what happens with men. And so if you're like I am, you go to your pediatrician primarily because your parents make you, and then after that you get a sports physical. And sports physicals are pretty much turn your head, cough, you don't have a hernia, get back out in the field and get going. And then we go into this kind of no man's land. Because the question I always ask is, who's the gynecology equivalent for men? Who's that person for men that kind of keeps us engaged in the healthcare system? And the answer is that specialty really doesn't exist now. That's part of what we're really trying to do with men's health is to create the gynecology equivalent. The term I use is androcologist, where we would have that same idea of either handing men off to primary care or filling that gap. Because for the most part now, men, we're reactive. So usually men present to the healthcare system when there's been some sort of acute crisis that brings us back. So if this is some general things that I believe. I think that this rate of premature death is really and suffering is unacceptable. We really need to do something about this sooner rather than later. This exacts a huge both financial and emotional toll. If you look at who really pays for the fact when men go down early in the prime of life, certainly we as men pay a price for that, but so do our families, our children, and other society in general. So we need to look at how can we create a solution to this. And when I say that we need a new paradigm, what strikes me, and these are of course not real patients and families that I see, but they could be, because what really strikes me is two things. One is I'm seeing younger and younger men come in to see me, and I'll describe a little bit more about my practices in the next few slides. But when you look at the whole family, what really strikes me is when we pick up chronic disease and problems in men, this really does have an impact on the entire family. So we're going to talk about sexual medicine, and I'll define sexual medicine more. Really, what I look at is erectile dysfunction, low testosterone. You can include urinary symptoms, something called LUTS, lower urinary tract symptoms, and that men get as their prostate enlarges. You could also include something called Peyronie's disease or penile curvature, which I'm not going to talk about tonight, but it's a condition that we often see. And you can also include a premature or early ejaculation. So sexual medicine to me is a way to engage men. Some of the symptoms that we talk about will engage men into the healthcare system, and from there, the idea is how do we get you engaged and keep you in the healthcare system. So it's a whole process of education, entertainment, engagement, and then empowerment. And I'll go a little bit more into detail on that. So here, this slide really can summarize a lot, right? I mean, maybe this is the easy way to summarize my practice. I mean, when they say sex sells, it's true. Sex does sell, and it's a way that I found that will get men interested. I often say, if you look at the erection problems that we'll talk about, or the low testosterone or urinary problems, if you're not getting an erection, if you have no interest in sex and you can't urinate, generally I have your attention. And so what we try and do is utilize that to get men in the office and move on with this new experience. So we'll talk about sexual medicine as a differentiator, but first, what are the symptoms? So what are some symptoms around men's health that I commonly see that are important? Well, you can do lack of energy, diminished sex drive. Those can be associated with low testosterone. Poor concentration and memory loss, that can also be associated with low testosterone. Difficulty getting or keeping a firm erection is in the area of erectile dysfunction. What about you don't have any symptoms? Well, I put that in there just to remind us that prostate cancer actually can occur with no symptoms. The best thing you can do in terms of symptoms for prostate cancer is to get your yearly physical, your physical exam with both the blood test called the PSA or prostate-specific antigen that we'll talk about a little later in the program, and also that dreaded digital rectal examination that none of us like to do, but we really need to. Prostate enlargement can be slow urinary stream, hesitancy, frequent urination, inability to father children. That's a problem with male infertility, but that can also be a sign of overall health issues that a lot of times in younger men, I'll pick that up, and it can impact their sperm counts and things like that. And then there's the early ejaculation issue. So a number of symptoms that we can look at. Now, if you look at the three major symptoms, and I'm going to talk about primarily, well, I'll mention all of these tonight. The green ovals that you see, erectile dysfunction, low testosterone. LUTS stands for lower urinary tract symptoms, secondary to BPEs, benign prostate enlargement. I have some nice pictures of that later that'll show as your prostate grows, you get these urinary symptoms. But the way I use this in my clinical practice is that, especially erectile dysfunction, low testosterone, these symptoms are linked to the outer medical conditions. So I can map men with ED, low testosterone. That can put you at increased risk, either as an early warning sign, or you can have the problem with any of the cardiovascular diseases. So we can look at sleep, heart disease, high blood pressure. We can look at renal failure. I can look at diabetes or pre-diabetes. I can get into some of the mental health issues. We can talk about smoking. We can talk about some of the urology issues with prostate cancer. All of these can map back to symptoms. So when I think about erectile dysfunction, I say erectile dysfunction is often a symptom of other things that can happen. So ED can occur anywhere from 3 to 6 years, say before you have a heart attack, a stroke. It can occur before diabetes, and we'll talk about. I'll go through all of these. So one thing that you can think, and is that the heart wasn't the Tin Man's first organ of choice. So hopefully by the end of my talk, you'll know what that organ of choice was. I have to kind of watch myself when I give this talk, because as I talk to younger and younger kids, like some of the younger medical students, things like that, I kind of date myself, because a lot of them don't, they aren't even sure what I'm talking about. So I have to kind of point that out to them. But anyway, let's go a little bit. So if you look at the theory behind getting an erection starts with stimulation. So you get stimulation, and then you get the real male brain here. That's actually sexual excitement, and that will lead to getting an erection. So when you get stimulation, what happens is the body releases a substance called nitric oxide, and nitric oxide really relaxes the blood vessel tissue, so it opens up the arteries and the veins, and you get blood flow. So I have this one anatomy slide that I just want to give you an idea of how this all works. So here's the penis, of course. If you all remember John Bobbitt, remember poor John Bobbitt, he got his penis cut in half, or he got his penis cut off. So if you cut the penis in half, you actually get these two cross-section images. The bottom is the flaccid or non-erect state, and then there's the erect state up top. So the blood flow pattern in the penis, it goes initially into these small arteries. These are called cavernosal arteries, and it then flows into these smaller branch vessels called helocene arteries, then into these sinusoidal bodies that look like little lakes, and these lakes are lined with what we call endothelial cells, and then it goes out into the veins, back into the circulation. So that's how the blood flow in the penis works. Now, the important thing to realize is the whole process of getting an erection has to do with relaxing what's called smooth muscle. So you have smooth muscle that's present here in the arteries, and when you relax that, it opens the arteries up, you get blood flow, and you get swelling of the penis, or what we call tumescence. But to get a rigid, firm erection, you have to block the outflow, trap the blood in the penis. And that process involves relaxing what's called trabecular muscle, and that's pictured in yellow here. So if you can imagine, if you relax that smooth muscle, what happens is these sinusoidal bodies expand like balloons, and when they expand fully, they block off the venous outflow and they trap the blood in the penis, so you get a rigid, functional, usable erection. And the reason that that's important is the earliest symptom of erectile dysfunction, the earliest symptom is when a man says he can't keep or maintain a firm erection. That's the early symptom. That is usually years ahead of a heart attack, the stroke, the diabetes. And the reason is the penis is just, you can almost think of it, it's like a barometer of your overall health. It's a perfect vascular organ, and this early sign has to do with poor erectile function that's really independent of blockage. Everybody thinks about blocking the arteries. Blocking the arteries is certainly important, and the penile arteries are much smaller than, say, the coronary arteries leading to the heart, or the carotid arteries that lead to the neck and give you a heart attack or a stroke. So I can think about erectile dysfunction as a heart attack or a stroke of the penis. It can be a very early finding, and there are very good medical reasons why that happens. So this is just a simple way to think about this. The penis as a cylinder. If you fully relax all the muscle, then the arteries, more flows in from the arteries, you block the veins, you get a good rigid erection. But what can go wrong? Well, either you can block the arteries, and that's, if you think about filling a bucket up, if the faucet only drips, then what happens is you're never going to fill that bucket up. Or you can think about the bucket having a hole in the bottom. And if it has a hole in the bottom that's big enough, you can have the faucet running full steam. It doesn't matter. It's going to leak out just as fast as it runs in. So if you read a textbook, they call this poor maintenance venous leak. And the reality is that really isn't a good name for it. It ought to be called poor penile smooth muscle relaxation disease, but no one's going to say that. And we keep calling it venous leak. But the message is that it's really a vascular problem. And so that's why, if you look at, I tell people, look, blood vessel disease anywhere is blood vessel disease everywhere. So the penis is often the first manifestation, but it can be a sign that you've got other things going on. And one of the things that we do a lot nowadays is we really are very proactive about making sure that you get a full cardiovascular evaluation when you come in with erectile dysfunction. As a matter of fact, if you look at men who I see in, say, 40 to 49 years old who come into me with erectile dysfunction, if you're 40 to 49 years old, if you look over a 10-year window compared to men who do not have erectile dysfunction, you have a 50-fold increased risk of developing a major event, a heart attack, a stroke, something like that, in that age range, if you have ED versus if you don't. Now, if you're 70 or over, that association goes away. So in somebody in their 70s who has ED versus somebody who doesn't, you don't see that same associated risk. So really the men in their 40s and 50s are ones we really ought to be asking about if you have erectile dysfunction. It does have great predictive value. So for this slide, just look at the left-hand side, the canary in the coal mine. Erectile dysfunction is the canary in the coal mine because you can have actual clinical disease where you have your heart attack or your angioplasty. You have subclinical disease, which is disease that we haven't picked up yet. And then you can have undetected risk factors. And the point that I often make is early on when men begin to have difficulty keeping a firm erection, what we call early stage ED, that can be at the subclinical or undetected risk factor level. Men tend to think that erectile dysfunction occurs when you no longer get a firm erection, and that is end stage or late stage ED. That the cat is out of the bag at that point. So I'm going to switch gears now, and I'm going to talk a little bit about testosterone. So I'm moving pretty quickly through this, but I want to cover everything so we can get to any questions that you might have. So testosterone is a very interesting topic nowadays. When I was going through medical school, which was many years ago now, low testosterone really was a sex hormone. The reality is now that it's not just a sex hormone. It is actually very closely linked to chronic disease, hypertension, diabetes, things that we'll talk about. It's low T is probably more prevalent than we think. A lot of people still are not being evaluated for you because a lot of times doctors aren't getting the testosterone test. But you can see this in up to 40% of men. The message I want to leave you is that this can be a marker for increased. When I say cardiometabolic risk, that means cardiovascular risk, heart attack, stroke, diabetes, and things like that. And it's also an increased risk for mortality or death. And so why is that? It's because if you look at low testosterone, it can be associated with obesity or being overweight, hypertension, abnormal cholesterol called dyslipidemia, elevated blood sugar, insulin resistance is another way of looking at the blood sugar, something that you can call the metabolic syndrome, which is or the individual components. But these are associated with low testosterone. As a matter of fact, many of us believe that low testosterone ought to be a component of metabolic syndrome, and it's something we need to look for. And here's the real culprit. This is the real culprit. Look at it's the belly fat, the way that we eat nowadays in the United States. It's the abdominal waist. If you're a man, your waist circumference measured at the belly button. You can't cheat and do your pant size because that doesn't work. That doesn't work. Measure your waist circumference at the belly button. It should be less than 40 inches. And if it's not, there's a problem. So if you look down, and I always say I won't give you the full version of the joke that I tell guys in the office. But the bottom line is I was having trouble communicating to men the risk factors of having a big belly. It's the belly fat. So I finally would have them stand up because they would look at me and say, I don't understand why I have low testosterone. And I say, stand up and look down. And you see this guy, you look down and I say, if your penis doesn't show up, or I would say, if your dicky do not show up, then that shows that there's a problem. And I started doing that as kind of a joke, but then what happened was it really got the message through to the men because they were like, so you're saying it's my belly? I said, yeah, that's exactly what I'm saying. And when we treat testosterone now, a lot of this has to do with this waist circumference. If you were to lose that, that's one way of treating testosterone without these different medicines. So this abdominal fat is bad for a number of reasons. It increases the level of estrogen, so testosterone can be converted to estrogen, and there's an enzyme in the abdominal fat that does this. And so estrogen, for men, you want some estrogen, but you don't want high estrogen levels. It can release inflammatory mediators that can contribute to cardiovascular disease, and it can also impact diabetes. So that's important. In terms of getting evaluated for low testosterone, the main thing there is there is a serious way to do this. I mean, we look at they're different ways, but my advice would be you need to get testosterone levels. We get at least 2 morning testosterone levels, and we do a full evaluation around testosterone. But it's an important part of life. Only point I want to make off of this slide is that there are a number of treatments. We don't have an oral medication yet approved here in the United States. People are working on that. But you can do injections, you can do gels. Gels are daily, injections can be every week, every other week. There's some risk associated with testosterone, and I have a list here. You can have, it can raise your hematocrit. If you have sleep apnea, we usually work that up before we treat you with testosterone. This does it worsen prostate enlargement? And the answer is that's written everywhere, but honestly, I've never seen that. These are the question I often get asked about is the relation between testosterone and cardiovascular disease. And what I'll say here, I don't think I put it all in there. So what I'll say is that there are a couple things. One is there's some papers that came out that looked at this relationship. The bottom line is that low testosterone can be a risk factor for increased risk of cardiovascular disease. The jury is still out on does testosterone replacement therapy trigger cardiovascular events. What I can tell you is the papers that came out, or those papers that came out that caused this uproar several years ago, they were very poorly done studies. There are many papers out that also look at the benefits of testosterone therapy. So we don't have that long-term 20-year randomized placebo study that everybody wants. But I think the bottom line is you need to be assessed. If you're well assessed and you're symptomatic and you're documented to have low testosterone, it's something that we discuss, and I certainly do quite a bit of that in my practice. Let me just, so these are the things. Does testosterone replacement therapy give you prostate cancer? The answer is no. The literature is actually quite clear on that. Testosterone therapy does not give you prostate cancer. I tell men that if I treat you with testosterone and what's called your PSA, that blood test goes up, then you may have prostate cancer there, but you had an undetected prostate cancer. Testosterone did not give that to you. Can you treat men who have known prostate cancer with testosterone? And the answer is you can. We do this on an individual basis. Many men now who've had prostate surgery and the prostate has been removed and they have low testosterone, we do treat. But you can do this, and again, this is an area of specialty. And then I talked already about does testosterone replacement put you at increased risk for a heart attack or a stroke? So here's the bottom line I tell my patients when they come in is that if you look at testosterone replacement therapy, if you can, there's the addict, and then there's the basement, and then if you look at the basement, if your levels are too low, you can have low energy levels, you can have decreased libido, you can have some of the glucose problems, insulin resistance, blood sugar problems. If your levels get too high, that can cause some problems that we worried about with raising your blood pressure, raising your red blood cell count. But my job as your physician is to keep your levels in the house and with monitoring and follow-up. And if you do that, I think in the appropriate patient, testosterone replacement therapy is something that you can look at, and I certainly do quite a bit of. So let's shift gears again. I'm going to talk a little bit about the prostate. So there's the prostate. You see the prostate here that sits between the bladder and the penis. So the urine has to flow from the bladder through the inside of the prostate and on out into the penis. And you can see that the prostate here surrounds the urethra or the urinary tube. So as the urine flows from the kidneys into the bladder, out through the prostate, and then through the penis. So what you can see is that the prostate is in a central position to cause problems with urinary flow. And so if you look at this side, what can happen is with benign prostate growth, what we call benign prostate enlargement, the inside of the prostate can grow and it can squeeze off the urethra. So you can see bladder here, penis is down here at the bottom. Is when you get this growth on the inside of the prostate, it can block the flow of urine, so you get these symptoms: slow stream, straining, hesitancy. Over time, what can happen is it can actually cause your bladder to do what we call hypertrophy, become very muscular, and over time the bladder will actually just weaken, give way, that's what you don't want to have happen, because then this increased pressure can back up into your kidneys, and so you can get kidney damage. Now, that's what we don't want to have happen. So when you get some of these urinary symptoms, that's when we really want to see you and have you come in. Now, the prostate enlargement on the benign level happens on the inside of the prostate. Let me just back up here on one slide. If you look here, the prostate cancer occurs on the periphery, on the outside of the prostate. So that's why we have to, all as men, we have to get that dreaded rectal examination, right, where the finger goes here into the rectum. And the reason is you're actually feeling the texture of the prostate to see if you can feel cancer or some other abnormalities. I have plenty of men that can have a large prostate and they're being blocked on the inside, but I can feel a large prostate, but I don't feel anything cancerous. And I have also plenty of men who have a small prostate where it feels normal sized, but the real blockage is on the inside that I cannot feel. So there's some symptoms here, and I've talked about these already, include emptying, frequent urination, going urgently, straining, weak stream. We have questionnaires that we can give you to pick these up that give us an idea of how significant your urinary stream flow is. The bottom line nowadays is there's some medicines that we can give you. There are plenty of minimal surgical interventions that we can talk about. A lot of men are familiar with what used to be called the Roto-Rooter, where you go in and you core out the inside of the prostate. A lot of the times the treatment is based on when the symptoms become significant, a significant bother to you. This LUTS, or this lower urinary tract symptoms, it's interesting that this can again be a predictor of undetected disease, especially getting up a lot at night. So these are things that you don't want to wait around on for a number of reasons. Now, prostate cancer, this is a lecture in and of itself, but it's very, very common. As I mentioned, you want to get the rectal exam. You also want to get that PSA, the prostate-specific antigen blood test. There was a lot of talk a few years ago because the Preventive Task Force had recommended not screening anymore for prostate cancer. They have backed off of that recently. The current recommendations are if you're a white male over age 50, you ought to have a yearly PSA, or you at least ought to have the discussion with your doctor. If you're an African American man who's over age 40, you should begin screening. Exceptions to this rule are if you have a family history of prostate cancer, whether you're black or white, the screening ought to be earlier, at least at age 40. My African American patients who have a family history, I actually have them start at age 35. Important, because your first symptom with prostate cancer may be when the cancer is there and spread. So we really do you really do want to get your examination. And I've said a lot of this, so I'm gonna go on. And let's move on to effects of sleep. So I'm gonna talk about other things in men's health that can impact you. So what about poor sleep? A lot of things can happen when what I've become aware of is, I think in the past, I know I had way underestimated sleep. And when I was at Hopkins, I became very good friends with one of the sleep medicine physicians there, and she really impressed on me the importance of sleep. I mean, it can impact a lot of the men's health issues I look at: decreased libido, weight gain, so it can lower testosterone. I've had people who've come to me and we just had really poor sleep hygiene, and their testosterones were extremely low. And I can think of several patients who would get ready to treat them, and on their own they kind of changed their sleeping patterns, and their testosterone almost normalized. So poor sleep can have a number of things. So here, choosing the correct, I put this up just because I thought it was kind of a fun thing. What's the correct statement? And I'll give you the answer here on this one. It's actually D. 30 to 40% of Americans admit to nodding off behind the wheel monthly. So quite a few. Here's a question that you've seen before. So getting less than 6 hours sleep. So what does this do? And the answer is, it does all of the above. It increases your obesity, stroke, and diabetes risk by 20%. It increases coronary artery disease risk by about 30%. So all of the above, getting less than 6 hours sleep. This is especially worrisome if you're getting less than 5 hours a night. That's not good. 5 and 6 put you at risk. You want to get over 6. And I must admit, when I looked at myself between being a medical student and a resident, and even in medicine in general, I'm not sure how I even kept any health when I looked at this 6 hour sleep rule. So I must admit, this was a real jolt to me. I really do make an effort now to get as close to 7 hours as I can. It's a bit of a struggle because I can be a night owl and I always get up early. But when I looked at the health list, I can say that I really do make an effort now to follow this rule. Sleep apnea. What are some of the common conditions? Apnea is quite common. You see, 2 to 4% of Americans have apnea. As many as 90% of individuals are undiagnosed. I can tell you that I pick a lot of this up when guys come into me with low testosterone or with erectile dysfunction. We pick up quite a bit of sleep disorders. Apnea is number one. It can put you at risk for high blood pressure. It can put you at risk for a number of different things. So snoring, that sort of thing, something that we really do look at. Insomnia is important too. That can be difficulty falling asleep, difficulty staying asleep, waking up too early. Bottom line is with insomnia, you also, and you don't have to worry about this, the point I want to leave you with is that there are a number of medical disorders that are more prevalent when you have insomnia. So this is something else that we screen you in our clinic. We really take a close look at, not only exercise, fitness, sleep, a number of different things. So I'm going to finish up. We're going to talk a little bit about what I call the modifiable risk factors, and that can be food or nutrition, smoking, exercise, alcohol, and moderation. So obviously, smoking cessation is important, right? So I don't have slides on that, but that's important. Exercise is quite important. Alcohol or moderation of alcohol intake. It always surprises me some that when you really get an alcohol history on patients, what some people think is just not a big deal. Is in terms of alcohol intake can be quite significant. I remember one patient of mine who he used to enjoy red wine each night, and a lot of us do. I like a good glass of Pinot Noir myself, but I asked him. I said, well, about how much, and he said, oh, I drink a bottle a night. And I looked, I said, a bottle every night? And he said, oh, yeah, but that's not really that bad, Doc. I mean, it doesn't even give me a buzz anymore. And so that really just kind of struck me like, boy, you really need to go over people and take that history and bring up that point. But let's talk a little bit about food, because this is a topic that I am extremely interested in now is nutrition, because nutrition can really impact this. So when men come to me with erectile dysfunction or low testosterone, the problems I see, I tell them, look, I can give you the quick fix and put you on a medicine, this and that, but my real thing is, what's the underlying cause for what you have going on, and how can we address that as a way of focusing on the improving the sexual health issues. So this is what a lot of us as men enjoy. I tell you, I when I moved from Baltimore down to Nashville, we love our barbecue down here, and but it's interesting. So but I want to just show you what some of the things. So if you look at, say, meat, so meat or even fish, cheese, eggs. This is what happens in terms of what happens in your gut. So when you eat these, the gut flora will actually metabolize. You eat this and you get choline. So choline, when it goes through your intestine, your gut flora will come out with a substance called trimethylamine. It's TMA here, and that will go into the liver, and then you get trimethyl N oxide. So these names are fancy, and it doesn't matter. The bottom line is this: the TMAO can have a dramatic effect on atherosclerosis or increasing the risk of cardiovascular disease, heart attack, stroke, things like that. Very important, and a lot of it has to do with getting back to your overall gut flora. So eggs, milk, liver, red meat, shellfish, these are all sources of this choline, and in the gut it gets metabolized to this TMAO, and then what happens is you promote inflammation. All these things that can impact your overall cardiovascular health can be affected. So if you look at diets that can change this, vegetarian, vegan's probably the best. Vegetarian diet would be second, and there are other diets. So I'll tell you just a short story, and then I will end up so we can get to the questions. About 6 months ago, I've changed over to a vegan diet. And I'm going to tell you, I was a full-blown carnivore. And what happened was a friend of mine, a physician friend of mine who's in the public health, kept challenging me to come to one of his, he gives a course on nutrition. So I went to one, and it was for the general public, but they had the top, some of the top speakers in the country, and they really presented the evidence on using nutrition and the plant-based diet to really reverse the risk of heart disease, reverse diabetes, and things like. And so it was so shocking to me that I was like, this is something that I really need to think about, both for myself and for my patients. And so now, what I'm starting up in my clinical practice is to give guys the 15-day challenge. And that's not to make you a vegan. I'm not the meat police, but it's more to say, if you do this, this is a way I know I can control what you eat, and I believe that you're going to see changes. So we see changes in blood pressure, cholesterol, blood sugar, erectile function, a number of different things. But I tried this myself because I don't think it's fair to ask a patient to do something that you haven't done. And I'll tell you, after 6 months, your taste buds change. It hasn't been nearly as hard as I thought to do this. Better energy, better sleep. And so I'm really starting to implement this into my clinical practice. And again, you don't have to be, everybody doesn't have to go vegan, but the idea of just eating healthier. So I'll finish up. These are just, if you look, this is a family in India. Here's a family in China, and then here's a family in the United States, right? This was a week's worth of groceries. So let me go back. India, and so if you look at India, the obesity rate in India is about 15%. If you look at China, the obesity rate there is about 30%. About 30%. In our country, it's about 60%. And a lot of it goes back to what? You can look at the diet, and those pictures speak for themselves. So just finishing up here, who's directing health care for men? I think that if you look at where men's health can be important, it's in this whole idea of can we impact men and get them into the healthcare system sooner. So just some questions to get you thinking about it. How many of you over the past year had an annual exam? How many had your prostate checked? And how many of you know these numbers? Because when I see my patients, you should either know those numbers or you should have them and you bring them in for me to see. Because a lot of times when people call normal, I don't think is normal, especially if you have erectile dysfunction or other things. And just here's some of these numbers. Bad cholesterol less than 100, good cholesterol greater than 40, fasting blood sugar less than 100, PSA, there's a range there, we can talk about it. Testosterone should be greater than 300, the range 300 to 1200. And so I'm going to stop there. And my bottom line to you is don't be afraid to ask questions. Please share this information. I think the nutrition is important. I think focusing on identifying the underlying cause of the problem is important. So we're in the midst of a new paradigm. I see a lot of attitudes changing, and I'll stop there because I want to leave some time for questions if we have it. So thank you very much.
Great. Thank you so much, Dr. Billups. Before we open it up for questions, we're going to have a few more poll questions here. You may have seen them before. We'll go ahead and get those poll questions out of the way. And then if you have any questions brewing, please feel free to continue to submit those, and we'll get to them at the end. So just going back over them, which of the following represent the earliest symptom of erectile dysfunction? And I'll let everybody answer. Okay,
All right. So I'll make a quick comment on that. So it's the inability to it's maintenance. That's the early symptom. If you lose it if you can't keep or maintain a rigid erection, that's the warning sign. And a lot of men think it's like when you don't get an erection anymore. That's a later sign. And that maintenance can start, it maybe be once or twice out of 10 times, and it'll just keep getting more and more frequent. People think I'm tired, I'm stressed. But poor ability to maintain or keep an erection is the early sign. And if I would catch everybody then, we could really improve the preventive health aspects. Okay.
Great, thank you. And on to the next one. Which of the following statements about testosterone is false? Remembering that low T refers to testosterone. All right, we got a split decision here.
A real little split here. So the correct one, which statement is false, is testosterone replacement is known to cause prostate cancer. Remember I said that it doesn't. And that is very clear in the literature now. Testosterone replacement therapy is not known to cause prostate cancer. Low T, yes, we believe the low T is a risk factor for a heart attack or stroke. So remember I said it's not just a sex hormone. Low testosterone has implications for your overall health, and I look at it as a risk factor. So do many other doctors now. And the belly fat, it's the belly fat that triggers that higher estrogen level. Belly fat is bad. It's everybody's enemy. So what happens is there's an enzyme in the abdominal fat that changes testosterone to estrogen, or what we call estradiol, and so that's not good. So the correct answer is known T therapy replacement is known to cause prostate cancer. That's the correct because it's false.
Great, thank you. And on to the last question for the evening. Getting less than 6 hours of sleep does which of the following?
Yeah, you guys nailed that one.
There we go.
Yeah, I gotta change that question. All right, so that's good.
Great. So that's the end of kind of our poll question to test the knowledge, and we've got a few questions coming in that Dr. Billups, I'll give over to you now.
Okay.
The first one is, quoting the question now, a number of us take aldactone to reduce the effect of decades of HCV-caused liver damage, but aldactone is anti-androgenic. Any ideas to overcome the effects of aldactone?
Yeah, you know what? The only way that my answer to that, because you're absolutely right, but usually you're on the medicine because you need to be on the medication. What I would say is I always look to minimize any other risk factors. So if you're overweight, again, looking at the waist circumference, are you practicing good nutrition, things like that you can naturally do to boost the testosterone. I also get that full evaluation I talked about with everybody, where I'll get your total and free testosterone, your estrogen level, things like that. But there probably isn't a good way, because there's a reason you're on the medicine, and so what I try and do is I would treat you as a symptomatic patient and work you up like I would like I would anybody else.
Great. Another question that kind of ties into that one. What first steps would you recommend in starting a more healthy lifestyle? Are there any more important factors than others in terms of sleep, eating better, exercise, etc.?
Sure. So I think the big three that you can impact right away are the food, exercise, and sleep. So let's just take sleep first. I mean, getting that, well, certainly more than 6 hours sleep a night. If you can get closer to 7, if you recognize that you're snoring, or your partner recognizes that you're snoring, or you're having insomnia problems, go ahead and get that evaluated and checked out. The nutrition piece, so again, nutrition, you can start by eating healthier, and healthier can just be cut down on the portions of meat, increase vegetables. You can increase fruit, smaller but more frequent servings. That sort of thing. I went what in my practice. The reason I will oftentimes start people on the vegan is almost like a shock test just to get you going. But you don't have to do that. Just practice healthier eating habits, and then for the exercise, my advice there is start slow. The mistake a lot of people make, and actually I've done this myself in the past, is you decide I'm going to really hit this. It's New Year's. I'm going to get out and do this. And so I remember, it's been many years ago now, but I went out and joined one of the gyms, and I got a personal trainer, and this was a young kid that just didn't know, and he put me through a P90X type workout right off the bat. And I remember sitting in my car for 2 hours after that workout trying to recover, and I wasn't too anxious to go back after that. Start slow. Do stuff you can do at home. Walking, exercise that, do put-ups. A lot of things you can do at home and just advance yourself slowly. So that would be my advice. Getting started is the key.
Excellent, thank you. Then we've got one last question, which is, are the symptoms of low T similar to the symptoms of depression?
Yes, that's a very short. Yes. The symptoms of low testosterone are just as you mentioned. They can be associated. They are similar to depression, and that is why usually when I see somebody, if we pick those symptoms up, we do screen you for depression. There are a few ways to do that with questionnaire, but that's why it's important to get the correct diagnosis for low testosterone. So that's why I'm going to get those 2 morning blood tests, as well. It's the blood test plus the symptoms. But yeah, the depression symptoms definitely can mimic low testosterone. So then but I've also seen men who had low T with depression symptoms, and when you actually treat their testosterone, the depression improves. So you have to be on the lookout for both.
We just had one more question come in. Any thoughts on melatonin and any related pharmacons?
So melatonin in terms of sleep, I think that can be looked at as a natural sleep aid. What I use sometimes, you can get one of these ointments skinned with lavender. That can help with kind of natural sleep, because at least it helps me fall asleep. But yeah, I think that there are some of these natural things that you can look out, that you can use. I really have gotten to the point where I really recommend to the guys that come in the clinic, if I pick up sleep problems, I really send them in to a sleep medicine expert who just to get evaluated, and they'll go over not only the natural ways, but other ways to do it. Just because I'm now just come to the belief that sleep is so important. And as a physician, I'm embarrassed to say between sleep and food, I probably ignored that way more than what I should have, but I don't anymore.
And Dr. Billups, I'm sorry to do a little correction here. I misread. It wasn't melatonin, it was melanotan, a synthetic sex hormone.
All right. So I don't have a lot of experience using that. For the sex hormones, I pretty much stick to either testosterone replacement, if you need, or there's some other ways that you can increase testosterone. There's a medicine called Clomid that's a more natural. I shouldn't say more natural. It stimulates your testes to produce testosterone. I have rarely used HCG as another way to stimulate the testes. So that other one, I stick away. A lot of people do growth hormones. They do a lot of different things. I don't do that. If someone's really interested in that, I send them out to an endocrinologist, just because I kind of stick with the ways that I think are more straightforward in terms of especially raising testosterone.
Excellent. Seeing no more questions, so just wanted to once again thank you, Dr. Billups, for your insightful presentation, and thank you all for attending this evening. This webinar is being recorded and will be available shortly on HFA's website through the resource library. If you have any questions, please contact webinar@hemophiliafed.org. That's webinar@hemophiliafed.org, or simply reply to the webinar confirmation email you received. We also ask you to please complete the short evaluation that will pop up on your screen once this webinar concludes. And thank you, Dr. Billups, once again, and thank you all, and have a wonderful evening.
Thank you. Good night, everybody.